Hello, I'm Kaye Ervin from the University of Melbourne. I'm part of the Rural Health Academic Network, and I'm presenting on behalf of all of the researchers involved in this project. We have Dr. Chun. He's the Medical Director of NCN Health, Reid, who's also part of the Rural Health Academic Network based in America, and Elizabeth Smith, who is our infection control nurse. NCN is an amalgamation of 3 health services, Nathalia, Cobram and Namerka, and we amalgamated mid last year. Our project used implementation theory, which is intended to help people better understand what works and why. So that was the theoretical background of our study. It had ethics approval, and the aim of this was to better understand what worked for prescribers and what didn't. So what could we do to help and have optimal prescribing across all of our health services when it came to antimicrobials. We thought it was important that it be place-based. So there are lots of interventions in different studies, but we wanted to understand what would work for us. The medical director emailed all of the medical practitioners involved in the study, inviting them to undertake an interview with myself, and the directors of nursing of the 3 different health services emailed senior nursing staff, and we had 7 medical practitioners and 13 senior nursing staff who agreed to participate in the study. They contacted me and I interviewed them in the workplace, and when we analysed the results, what we found was unreservedly, without exception, everyone saw nurses as the gatekeepers to antimicrobial initiatives. And in that way, what they were telling us was they valued being prompted by nurses around what was appropriate and what was not. And nurses had no hesitation in prompting GPs in using optimal prescribing methods. Nurses themselves saw antimicrobial stewardship as being part of a worldwide link. So it was around better use and trying to reduce antimicrobial resistance. Medical practitioners actually perceived it as being something that we did for accreditation, so very much a local level program, and it was more about, for them, educating them as individual prescribers. But what everyone agreed on was that any sort of intervention should be around improved documentation and around better access to antimicrobial prescribing guidelines. So as a result of this study, what we've done is there are posters in aged care that prompt them to stop and have a look. Do they meet McGee's criteria for the definition of infection? And in the acute wards, it's a prompt to say, is this the correct antibiotic, and have you checked the therapeutic guidelines? In both areas, we have a ready reference for prescribers to look at, and that was developed through auditing what were the most common presentations and then just giving them a ready reference, which they were prompted also to look back at the therapeutic guidelines if there was anything that was unclear. We also, in aged care, put in a reference to McGee's criteria so that they could look at what the definition of infections are. So those interventions went into place in August, and we will look at our prescribing trends for 6 months before, for this 6 months while the intervention is in place, and we'll also look at it again 6 months post to see what's been maintained and what hasn't, and indeed whether it has made any difference. So what this particular project did was enable us to identify what were acceptable interventions for everyone and to introduce those. If anyone wants to know more detail about this study, it's been published in the Journal of Infection, Disease and Health earlier this year. So thank you.